Hello guys, this is Dr. Ajinkya here. In today's lecture, I'll be discussing about the various approaches a skull-base surgeon can have to access the intracranial as well as the intranasal tumors involving the skull base. So as we go from the anterior to the posterior aspect of the skull base, we know that that's the first. We have the transcribriform approach where we go through the cribriform plate. Then we have the transplanar approach where we access the roof of the sphenoid. Then the transtubercular approach where we can go through the tubercular strut of the sphenoid bone. Then the transcellular in case of pituitary, macro and the micro adenomas. Before that, we can also have an access to the third ventricle. That is a supracellular approach to the third ventricle. Then we have the transclival and the transodontoid approach. So today I'll be discussing about the basic anatomy through the cadaveric dissection and various surgical steps I'll be discussing about, and the various basic anatomy of how you can actually approach for a transcribriform surgery. So to begin with, we should definitely know about the anatomy of the transcribriform approach. Now, if you're a skull-based surgeon or an ENT surgeon working along with a neurosurgeon, definitely cases in case you can encounter when the tumors of anterior cranial fossa, such as the esthesioneuroblastoma, the olfactory meningioma, or the sinonasal carcinomas, such as the adenocarcinoma or the squamous cell carcinomas, those which have a lot of attachments to the skull base, maybe to the skull base bone or the intracranial dura, you have to approach particularly to remove those tumors for a oncologic free margin, for an oncological safe margin approach. So endoscopy is the best method to approach. And before we start operating, we definitely should know the anatomy. Now, well, in front of you, this is the sagittal cut section of a cadaver, where you can see actually, you can see this is a blue dotted line, which is showing you the anterior posterior length of the frontal sinus, which normally ranges from an average of 1 centimeter and can go up to a maximum of 2 centimeters. The broken white line you can see is from the posterior table of the frontal sinus right up to the sphenoid sinus anterior wall, that is the planum sphenoidale. So this is basically the transcribriform approach. So the basic anatomy of the transcribriform starts from the posterior table of the frontal sinus to the planum sphenoidale. So if you are a skull-based surgeon, you want to walk through a transcribriform approach, you definitely have to stay behind the frontal sinus posterior table, which is your anterior limit, and the planum sphenoidale, which is your posterior limit. And the lateral limits are both the orbits, that's the lamina papi ratio. So this is a corridor you have to walk in. Now you can see posterior to that, this is the area of the planum sphenoidale. This is a sphenoid sinus, as you can see, and that you can see that's the roof of the sphenoid sinus, which is the planum sphenoidale. And you can see this is the internal carotid artery and olfactory bulb area, and this is the cut section of the brain above. So as you can see, this is the area of the transcribriform approach, and exactly above that you can encounter the frontal lobe, and this part of the frontal lobe which you can encounter during the transcribriform approach is called as the gyrus recti, and if you go anteriorly, this becomes the orbitofrontal gyrus. Okay, so basic structure of the anatomy is the posterior table of the frontal sinus up to the planum sphenoidale. So that should be your anatomy. Now, the length of this transcribriform ranges from an average of 2.5 centimeters to a maximum of 3 centimeters. So 3 to 3.5. And this area of the planum sphenoidale is same as that of the frontal sinus, which can range from 1 to 1.5 or max up to 2 centimeters. So it's very important to know the dimensions and the variations of the dimensions if you're working on a skull-based surgery in this area. Okay, so this is a rough figure showing you the basic margins of the transcribriform approach. Now, this is actually a superior view of the skull seen from above. So this is, you can see this is a frontal bone, that's the outer table, this is the inner table, And you can see this is the inner table, this is the frontal bone. If you go, this is the anterior aspect and this is the posterior aspect. And as you go posteriorly, exactly behind the frontal bone and in between the cribriform plate, you see a small opening over here. That's the foramen cecum. Remember, you are watching this from the superior aspect, so you can see this is a foramen cecum. Now, this foramen cecum actually is not present in an adult stage. Very rarely it can be present, because if it fails to close, this foramen cecum persists, and if this is the case, it can lead to the persistence of the persistence of this foramen can lead to the meningoencephalocele or encephalocele, or the dural prolapse from the anterior cranial fossa to the intranasal cavity. So if that's the case, you have to be very sure that you examine this very thoroughly. So that's the frontal table, that's the foramen cecum right there, and immediately behind starts the cribriform plate, and on either side of the cribriform plate you have the fovea ethmoidalis, that is the anterior and the posterior skull base. So that's the cribriform plate, that's the fovea ethmoidalis, and that's the ethmoidal skull base, and on either side you can have the lamina papyracea on this side. So that's the cribriform plate, and you can have the Crista Galli over here, and that's the planum sphenoidale. So that's the roof of the sphenoid sinus. So the basic transcribriform approach exactly lies from the posterior table of the frontal sinus up to the planum sphenoidale. So that's the basic anatomy of the transcribriform approach. This is an endoscopic view of the cadaveric dissection, where there's a rough figure. You can see the extent, the anatomical extent. Now, this is the endoscopic view. So this becomes the patient's right side, and this becomes the patient's left side. So right, and this is left. This is after all the tissues has been dissected. You can see the lamina papyracea on both the sides. So the two lateral boundaries, as I said, was the lamina papyracea. The anterior limit was the posterior table of the frontal sinus. As you can see, this is the frontal sinus. A draft 3 has been performed over here to have a better anterior access to the cribriform. So this becomes the posterior table of the frontal sinus. This becomes the anterior and the posterior ethmoidal skull base. That's the fovea ethmoidalis. And this, you can see over here, is the cribriform plate with the septum in midline, which has been cut up to its insertion. And this is the middle turbinate, so which has also been cut. So this you can see in between the septum and the middle turbinate, you can see the olfactory fossa. That's the olfactory fossa on each side of the septum. So, and that's the sphenoid behind, and that's the planum sphenoidale. So whenever you're concerned with any esthesioneuroblastoma, meningioma, or any sinonasal carcinoma of the anterior cranial fossa, whenever the tumor on the CT scan or the MRI is involving the dura of the skull base, you have to take this approach, where you have to go bilaterally. You have to do a superior septectomy right from the anterior aspect to its posterior aspect. Okay, so this is a rough anatomy, and you can see over here on both sides, that's the anterior ethmoidal artery along with the nerve. Similarly, you can see the posterior ethmoidal artery with the posterior ethmoidal nerve. So the basic structures which should be visible for to a skull-based surgeon endoscopically while operating is the frontal sinus posterior table, beyond which you should not go. On either side, you have to localize the lamina papyracea, and the posterior aspect should be the planum sphenoidale. And on each side, you have to visualize the anterior ethmoidal artery, the posterior ethmoidal artery, and the cribriform plate in toto. So this is in further another cadaveric dissection of, you can see this is a posterior table of the frontal sinus, and exactly posterior to it you can see the foramen cecum, and this is the Crista Galli, and this is the cribriform plate. You can actually see the various perforations in the cribriform plate for the passage of the olfactory nerves, and above which they form the olfactory bulb. You can see the Crista Galli. Now this is an endoscopic view of the cadaver. So you can see the foramen cecum very well only on submucosal dissection. You can see the Crista Galli projecting upwards, and you can see the various numerous perforations in the cribriform plate for the passage of the olfactory nerve. So basically you have to keep this anatomy in mind very clearly. So whereas the anatomy of the vascular structure is concerned, the two most important vascular structures which can be a major feeding vessel for the tumors in the anterior cranial fossa are the anterior ethmoidal artery and the posterior ethmoidal artery. Say for example, the tumor is extending from far behind to far anterior. The entire anterior skull base has to be dissected, and in some cases it may even have the blood supply from the branches of the anterior cerebral artery as well. Okay, so I'll be discussing about the branches of the anterior cerebral artery in this same video in some time as well. So as you can see, this is a posterior table of the frontal sinus, the cribriform plate, the anterior ethmoidal arteries. That's the sphenoid sinus, you can see. That's the carotid artery. That's the optic nerve, you can see. Okay, so basically 4 boundaries you have to always keep in mind. Lamina on either side, the posterior table of frontal sinus, for which you have to do a draft 3 always, not always, depending on the location of the tumor involved. And the posterior aspect is the planum spinoidale. So this is the area you have to walk inside, with a septectomy being done, and the approach is bilateral. So moving on to the vascular anatomy in a transcribriform approach. Now it's for a skull base surgeon, it's very important. It's not like you just have to remove the tumor and the operation is done. You need to know the blood supply of the tumor, the various anatomy of the blood vessels you can come across, because it's not very simple. So this is actually the skull specimen, the bone specimen. This is viewed from above. Okay, so you having a superior aspect view. This becomes the anterior cranial fossa. That's the middle cranial fossa. So you can see over here now, just this is a superior view, so as if you're looking from above downwards. So you can see this is the optic chiasm over here. That's the internal carotid artery, and that's the internal carotid artery giving off a branch. That is the anterior cerebral artery on both the sides. So that's the anterior cerebral artery on both the sides. Now the anterior cerebral artery has 5 parts. Okay, the A1, A2, A3, A4, A5. Okay, listen very carefully. The anterior cerebral artery is a branch of the the internal carotid artery, one of the terminal branches. So it has 5 parts: A1, A2, A3, A4, A5. Now the A1, as you can see over here, that's the A1. I have mentioned it A1 over here. Now from the origin of the internal carotid artery right up to the anterior communicating artery is the A1. Okay, that's the A1. I'll show you much better on this aspect. Okay, so this is the optic chiasm. That's the optic nerve, similarly seen over here. That's the optic chiasm. That's the optic nerve. So as you can see, this is the internal carotid artery, and this is the middle cerebral artery, and that's the anterior cerebral artery. So from the origin of the internal, up to the anterior communicating artery, that is the A1. So A1 has got a branch known as the medial lenticular striate artery, and further from the ACOM it gives A2. Now that's the A2. Now this A2 segment has got 3 branches. For now, as we are concerned with the transcribriform approach, this very same A2 gives off 3 branches, which we are gonna encounter while doing a transcribriform approach and a transplanar approach. So the very first artery you can see over here on the lateral aspect just above the ACOM is the recurrent artery of Huebner. As you can see over here, that's the recurrent artery of the Huebner. As we go above on the lateral aspect, you can see this is the OF, that's the orbitofrontal artery, and on the medial aspect, this is the frontopolar artery. So 3 branches from the A2 are the recurrent artery of the Huebner, the orbitofrontal artery, and the frontopolar artery. Now, this is the frontoorbital artery, and that's the frontopolar artery. Now, the frontoorbital artery is the single most important artery which we encounter once we remove the transcribriform plate. So once we remove the entire cribriform plate, the first vessel we encounter is the frontoorbital artery. As you can see over here, that's the cribriform plate. As you can see over here, that's the perforations you can see, and that's the cribriform plate. So if you remove that cribriform plate, what are you going to see? You're going to see the frontoorbital artery running like this, and you're going to see the frontal lobe, and also you're going to see the interhemispheric fissure. This is left cerebral hemisphere, this is right cerebral hemisphere, and this is the intercerebral hemispheric fissure. Also, you're gonna see the olfactory tract. I'm gonna show you the olfactory tract as well. So one thing you have to be very clear about, at the lower level, you're gonna see the frontoorbital artery running straight directly from its origin, and at a bit higher level, on towards the posterior aspect of the cribriform plate, you will see the frontopolar artery coming as a branch from the anterior cerebral artery, but at a higher level and more towards medially and posteriorly. So this is a vascular anatomy you have to keep in mind while working on a transcribriform approach. This is one more diagram. This is the left side, this is the right side, that's the skull base. This is the intracranial view, that's the intranasal view down there. So lamina on both sides, we have to work in this corridor in between. So as you can see, that's the anterior ethmoidal artery running in the skull base. That's the posterior ethmoidal artery running in the skull base. And in the intracranial aspect, above the cribriform plate, now what we see is the endoscopic view, which is the intranasal cribriform plate. But what I'm showing you here is the superior aspect or the intracranial aspect of the cribriform plate. So as you can see, the entire cribriform plate is covered above by the olfactory bulb. Now, what is olfactory bulb? Olfactory bulb is nothing but the union of numerous olfactory nerves, right? So this is the olfactory bulb, which forms the olfactory tract posteriorly. Okay, so it forms the tract posteriorly. So what you encounter, the first thing along with the frontoorbital artery, is immediately the olfactory bulb. So very sure, you have to be sure that you should not damage the olfactory bulb if the tumor is not involving that side. If the tumor is involving it, you definitely have to remove that. So you can see this is the olfactory bulb, and you can see just lying next to it and a bit above is the frontoorbital artery, and a bit at a higher level you can see the frontopolar artery. So this is a relationship you have to understand very clearly. So that's the olfactory bulb, that's the frontoorbital artery, and that's the frontopolar artery. Okay, so let's move further. Now moving on to the endoscopic view. This is the anterior. Now this is the left side, this is the periorbita, that's the orbital fat, that's the anterior ethmoidal cavity, that's the anterior ethmoidal skull base. You can see the anterior ethmoidal artery from the posterior lateral to the anterior medial aspect, and you can see the nerve also, which is running anterior to it. So if I show you very clearly, you can see it further here. That's the left side, that's the lamina papyracea, that's the Kennedy nipple sign, the orbital projection, that's the middle turbinate, that's the cribriform plate, and as you can see, it has a posterior lateral to the anterior medial course, and you can see the anterior ethmoidal artery very clearly and the anterior ethmoidal nerve anterior to it. So you can see even the branching of the anterior ethmoidal artery into the anterior falcine artery. Now this is the artery of the meningeal layer that supplies the meninges, the falx cerebra actually, the falx cerebra, that's also called as the anterior falcine artery or the anterior falx artery. So this is the artery which enters and goes intracranially and supplies the falx cerebri over there. This is yet another endoscopic picture of the transcribriform approach, where you have to expose lamina on both sides, the frontal sinus anteriorly and the planum spinalis posteriorly. So as you can see, we have to expose the entire skull base. We have to remove the entire septum in the midline from anterior to posterior aspect. We have to remove both the middle turbinates. We have to debride the entire mucosa. No mucosa should be left behind in this area. Only and only after removing all the tissues and the mucosa over the bone of the skull base, you will be able to drill, or you can make an osteotomy for the transcribriform removal. So, but before doing that, you have to make sure that you either ligate, you clip, or you cauterize the anterior and the posterior ethmoidal artery. If you do not do so, it's gonna have a considerable amount of bleeding, and it may even retract inside the orbit, and it may just prolong your complication and surgery time. So always make sure, if there's a thick bone covering the artery, you make sure you drill the bone with a diamond burr, maybe a 3 mm or a 4 mm diamond burr or a 2.6 mm diamond burr. You drill, make it eggshell thin, remove the bone with a Rosen's elevator or a Cottel's elevator, and you then clip the arteries, both the arteries. Now, clipping the posterior ethmoidal artery is more difficult because it almost always runs within the skull base. So you have to make the bone overlying it eggshell thin, and then you have to remove it. Only after cauterizing these two, you have to move forward. So the first step was to do a midline septectomy, remove both the middle turbinates, open up both the sphenoid sinuses, intrasphenoid septations, intersphenoid septum. You have to remove it all so that you can expose the planum spinodale as a reference skull base. Taking planum spinodale as a reference skull base, you have to keep on coming anteriorly, do an anterior and posterior ethmoidectomy, completely visualize the skull base of the anterior and the posterior ethmoids, do a frontal draft 3 procedure, expose the lamina on both the sides. So that's how you should proceed with the surgery. And once you do that completely, once you remove the entire mucosa over the skull base area, in this region, what you can see over here is you have to make an osteotomy. Now what you can see here is an osteotomy of the cribriform plate. So you can either do this with a kerosene sponge, or you can do this with a diamond burr. Always remember, you have to use a diamond burr. You cannot use a cutting burr, because it is gonna just cut through the bone and may enter the dura sometimes. So you can see over here, that's the frontal sinus area. A draft 3 has been done. This is a Crista Galli, and diamond burr drilling has been done all around the cribriform plate, right from the posterior table of the frontal sinus up to the planum spinodale right over here. Okay, so you have to drill the entire area in continuation. Now, almost always care has to be taken. You have to go from the anterior to the posterior aspect and not from the posterior to the anterior. So you always have to drill from the anterior aspect to the posterior aspect. Okay, so always remember that one thing important. And as you can see over here, the anterior ethmoidal and the posterior ethmoidal arteries have been cauterized and clipped so that to prevent all the bleeding. So once you do this osteotomy, you have to remove that bone. But there's one more important thing which we have left out. You can see over here, that's the Crista Galli. Okay, so as we all know, Crista Galli has an attachment to the falx cerebri, and also there's an artery running in the falx cerebri, a branch from the anterior ethmoidal artery and various other branches from the meninges. So there are two things. We have to cut the falx cerebri attachment from the Crista Galli. So first we have to make the Crista Galli eggshell thin, keep on drilling over it so it becomes easy for us to remove the Crista Galli. So once we expose the falx cerebri, we have to take an upward, or you can say we can take an angulated scissors, most preferably a downward facing scissors, and we can cut the falx cerebri. Now care has to be taken that we do not cut the vessels out there. We have to ligate the vessel first and then cut the falx cerebri. Now I'm going to show you how. So wait a second. Yep. So as I was saying, we have to do a frontal draft 3, expose the entire region, and after that we have to do this osteotomy like this, and here you can see once we do an osteotomy, the dura is still kept intact. Okay, once you do an osteotomy, now there are two methods. Either you can do first a osteotomy, remove the entire bone in toto and keep the dura intact. Second thing, you can do an osteotomy like this. You can do an osteotomy like this, and at the same time you can cut the dura with a dural knife scissor at the same time along with the bone. So you can remove the cupriform plate and the dura at the same time. So it depends on the surgeon what he is comfortable with. So either you can do the bone and the dura at the same time, or you can cut the bone first and then the dura afterwards. So once you do this, you can see this is the Crista Galli and this is the attachment of the falx cerebri, and care must be taken. You have to cut the falx cerebri with a sharp scissor or an angulated scissor. So this falx cerebri is still attached to the Crista Galli. If you do not cut this, the cupriform plate will never come down in single hand. So you have to cut the falx cerebri after ligating the vessels. So to understand the basic attachment of the falx cerebri to the Crista Galli, this is yet another diagram where you can see this is the anterior aspect and this is a posterior aspect. So anterior, posterior. So you can see that's the Crista Galli over there. The Crista Galli. This is the intracranial part. That's the frontal sinus. That's the cribriform area. That's the sphenoid area. So transplanar, that's the planum, and that's the cribriform plate. So as you can see, the anterior aspect has this Crista Galli over there, the bony upward projection, and you can see this is a falx cerebri. It's like a rainbow. It's like a shape of a rainbow where you can see actually it is a semicircle, the anterior aspect being attached to the Crista Galli. So whenever you're removing this cribriform plate over here, you come across the Crista Galli and you come across this part of the falx cerebri over here. Care must be taken. As you can see over here, that's the inferior sagittal sinus and that's the superior sagittal sinus. Okay, so the inferior sagittal sinus, when this is to all the skull base surgeons out there, the young ones or the new ones, listen carefully. So if you are gonna cut the attachment of the falx cerebri over here on the Crista Galli, remember this always, the inferior sagittal sinus is very close to it. So if you go much deep to cut it, you may end up cutting the inferior sagittal sinus, and that is gonna have a lot of venous bleeding. So care must be taken. You just have to cut the falx cerebri at the attachment of the Crista Galli and you're safe. So always remember this relationship. So this is the superior sagittal sinus, that's the inferior sagittal sinus. The inferior sagittal sinus, this is a great vein of, after which it continues as the straight sinus, and eventually it all goes into internal jugular vein. So that's the relationship. So remember, when you're cutting this falx cerebri attachment, don't go too high up. Okay, so moving on further. Now just remember this, we have removed this bone. Okay, we have removed this bone and we have removed the dura as well. So once we remove the bone and the dura, this is the picture we are going to see. Okay, so this is without the numerics and this is with the numerics. Okay, so this was the anterior aspect, the frontal sinus posterior table. See how important is it to know where exactly the posterior table of the frontal sinus is, and hence you have to do a draft 3 for a better exposure. So this is the frontal sinus posterior table, and you can see this is a falx cerebri in between. That's the falx cerebri in between, only in the anterior aspect. As I showed you here, this falx cerebri will be only in the anterior aspect and one in the posterior aspect. So this is the part you are seeing here. This is a part of the falx cerebri. You can see this. This is a falx cerebri over here. This is the falx cerebri part you are seeing over here. Okay, so that's the falx cerebri, and that's the olfactory bulb as I showed you. Now that's the olfactory bulb. That was the olfactory bulb over here, and which is forming the olfactory tract behind. So you can see this olfactory bulb, that's the olfactory bulb, and that's the olfactory tract forming behind. So as you go posteriorly, you can see the olfactory tract, and that's the frontal lobe, that's the brain actually. That's the brain, the frontal lobe, the interhemispheric fissure, you can see the falx cerebri, you can see the olfactory bulb, you can see the various numerous venous channels, you can see. And what you can see over here, the red one over here, is basically the fronto-orbital artery. That's the fronto-orbital artery. Furthermore, if you can go forward, that's the entire, see, that's the entire cribriform plate being removed. I can show you here. This was the cribriform plate over here, and we removed the cribriform plate, and this is a photo we can see over here. That's the sella, that's the optic nerve, that's the planum sphenoidale, that's the carotid, that's the clivus. This is an endoscopic view. Okay, so that's the sella, that's the sphenoid basically, that's the planum sphenoidale. So this is the patient's right side, this is the patient's left side. That's the frontal sinus over there, that's the Crista Galli over there. What you can see over here is the frontal lobe of the brain. That's the frontal lobe, which is covered with the arachnoid. Okay, you never touch the arachnoid. If you touch the arachnoid, it's gonna have a serious Csf leak, which is gonna be a complication post-op. Okay, so basically this is how you actually should approach for a transcribriform tumor, or any meningiomas or aesthesia neuroblastomas. So if you're working on aesthesia neuroblastoma, then always remember that whenever you're working on an aesthesia neuroblastoma or an olfactory neuroblastoma, you should know the grading of the olfactory neuroblastoma. Now there's a grading called as the Kadish grading, Kadish. That's the Kadish grading, which is into 4 alphabets, A, B, C, and D. And the another classification for the olfactory neuroblastoma is the Tnm classification. That's because it's a malignant tumor. The Tnm classification is also present. So always remember to check that out, the Kadish and the Tnm classification for the aesthesia neuroblastoma, the olfactory neuroblastoma. Also, I'll give you an example. This is a T1 post contrast of patient. You can see the post contrast enhancement of the tumor. This is the tumor on the sagittal section, as you can see over here. So you have to be very careful. You have to get an MRI done. As it is a tumor and it's an intracranial invasion with the dural uplifting over here, you have to go for an MRI. But also for a skull-based surgeon to know the bony landmarks, you also need to know the CT scan of the patient. So both the MRI and the CT you have to order and study it very carefully. So you can see this is a post-contrast MRI, and the tumor is actually involving the entire right anterior skull base along with the olfactory fossa, and the frontal sinus is also involved in this case. Also we also have a coronal view. You can actually see the tumor compressing on the orbit, and though it's not an actual invasion of the tumor, but it is actually invading and compressing on the orbital region as well. If you can see in the axial section, it is actually compressing on the medial rectus muscle over here, but it is nowhere involving the intraconal compartment of the orbit, so it is safe to operate on. This is the endoscopic picture of the tumor. You can see the polypoidal tumor on this patient. You can see the polypoidal tumor here. Now this is actually a case of an olfactory neuroblastoma, or you can say the olfactory aesthesia neuroblastoma, which commonly appears as polypoidal in the nasal part, but as you keep on going up, it becomes more of a kind of form. So it is very important to you to know that it may appear as a polypoidal tissue at first. So do not confuse that with an AC polyp or ethmoidal polyposis. You always look for the patient's history, the patient's age group, and you always ask for a CT And if you think that's an intracranial invasion, you go for an MRI as well, post-contrast. So that's the tumor over there. That's the right side. That's the septum. That's the middle turbinate. This is the endoscopic photograph of the live endoscopic surgery. You can see the anterior ethmoidal artery being cauterized over here. That's the lamina on both the sides. That's the frontal sinus. That's the posterior table of the frontal sinus. So on a live surgery, it's gonna be very bloody. So you have to be very well thorough with your anatomy. So this is a plenum sphenoidale. That's the carotid artery, and that's the sphenoid basically. So you have to work in this area. So once the entire tumor has been cleared off, the cribriform plate is opened up, and as you can see over here, this is a frontal lobe. And as I was saying before, you can see the first artery directly above it is the frontoorbital artery. That's the frontoorbital artery. And once you're done with the operation, once you remove the diseased dura and the tumor out of the nasal cavity, you have to do a repair. Now, for repair, you have to always have a Haddad flap prepared, the fascia lata from the thigh prepared, the fat from the thigh or the abdomen prepared well before. You have to take the patient's consent well before, and even before you start the surgery, you have to take your Haddad flap and a free graft as well. So this is how basically you can achieve a transcribriform approach without any complications. And if at all any complications occur, the most common complication is a post-op CSF leak, meningitis. You can also have a tension pneumocephalus or pneumocephalus. You can also have something called as a ball valve effect, because if you happen to put a lumbar drain at the end of your surgery to prevent excess intracranial tension, the excess lumbar drain can actually, pull and cause a negative effect or negative pressure in the brain and pull the brain tissue upwards. Along with it can also pull the repair graft apparatus into the intracranial aspect. So if the repairing part is not foolproof, and if by accident some defect is left behind, and if you put a lumbar drain which is not well put, it can actually cause a ball valve effect, so the air may keep on entering the brain, causing a tension pneumocephalus, which can sometimes be life-threatening as well. So you always have to remember, you always also look out for the intracranial hematomas. For hence, you have to cauterize your major vessels carefully. You do not leave behind any bleeding vessels, because it may lead to intracranial hematoma. So for that, your vascular anatomy should also be very important. Now, before I end this video, there's one more thing. Now, as I was talking about a lot about the esthesioneuroblastoma, the Kaddish staging, it goes like this. The Kaddish gave it 4 alphabets, A, B, C, and D. The tumor, in case of A, that's the first grade, the tumor is in the nose only. If it's a B, second grade, the tumor is present in the nose and the sinuses. If it's a C, that's the third grade, the tumor is well beyond the confines of the nose and the PNS sinuses. That means it enters into the orbit. It may enter the intracranial cavity, intradural, the dura may be affected. And the last one, which is a D, in which it may have a regional cervical spread, or may have a distant mets. So that's the basic malignancy spread. So you have to remember the Kaddish classification and the Tnm classification as well. So I hope you found this video really helpful, and to all the new young skull-based surgeons out there, I hope you do well if you are starting to do this transcribriform approach. In some time I'll be also uploading the various other approaches, which is a transcellular, supracellular, and the transplanar, transtubercular approach, the basic anatomical concepts and how you can approach in those surgeries, and what steps you can do to prevent any complications, or many more. So I hope you found this video really helpful, So keep subscribing, keep liking, and until see you next time. Thank you.